So the nega who Samara ARDS example, no? Good morning, everyone. Many are oxygen therapy down in the water. Dinero so case the ARDS pillar kama or to John in a touch piano. So ARDS are medical school don't let you that oh dibare or acute respiratory distress syndrome. To a criteria or to a few things for no. Now to a yoga to come home to a it is a syndrome today. So syndromes are all to a symptom in a composed slow terrible. No? To a criteria the black gas criteria sheet one of them no. Araga PaO2 divided by FiO2 less than 200 PI no. Higher the criteria meets people or arterial black gas low there. Or Davi Mele, Chiniga, or arterial black gas Maya in our ARDS level law so nearly surau, or oxygen below PNEUMOTHORAX and if you come on yard. So I don't know by any of your woman. Peter. Now that requirement the Kuwa, chest X-ray here. Chest X-ray matua patrile suro, bilateral infiltrate down opacity as well. Now the Kuwa, patient respiratory failure, it should not be because of congestive heart failure. Or down to go out or left-sided heart disease one. This is a typical image of or ARDS. You see that in patient is currently intubated on mechanical ventilation, and there is a bilateral infiltrate in both lungs. Very diffuse, extensive infiltrate. COVID babe. We have pathophysiology or the SARS to lungs alveoli now to it's taken up by alveolar macrophage. It activates or intracellular or these cytokines and mediator release. That just to understand the process of inflammatory response. Basically, the alveoli now, so end results also thrombosis yare, vasoconstriction, fibrosis, inflammation, and capillary leaks. So there are so many different pathways the same. Inflammation will piss the SARS virus, the COVID virus the complement activation. You see that or endothelial thrombosis or microvascular thrombosis. The pathway the chain lao yawabi solo shade brown glass or CTE and CT mapyara the lobe. The lens the CT scan yameso the go brown glass finding yawabi. The brown glass to the microscopically madari pinne surau one ali no. This is a process of ARDS. So it doesn't matter it's a COVID or H1N1 or influenza global PP. Anytime to our alveolar macrophage cells the activation pit time mediator release to our now by to our the alveoli what we call the hyaline membrane formation so Russia. Any kong pit so the alveoli to a gas exchange efficient pit or kajaro, any hypoxia yara pit. The PV eventually there is a fibroblast migration into the space between the alveoli and pulmonary capillaries. We call it interstitium whatnot. So I tell fibroblast when and when like the diffusion between the alveolar surface capillary ကပို့ပြီးတော့ဟို diffusion gradient က increase ဖြစ်သွားပြီးတော့ဒီ oxygen gas transfer impair ဖြစ်သွားတယ်ဒီနေ့အပြင်ဒါ hypoxia ကိုရစေရပေါ့နော် Now because of a lot of inflammatory exudate including neutrophils T cell macrophage a lot of inflammatory cells and what cellular debris တွေပေါ့နော် dead cells တွေရောအကုန်လုံးကဒီ alveoli နဲ့မှာတဖြည်းဖြည်းနဲ့ accumulate ဖြစ်လာပြီးတော့သူကဒီ alveolar တစ်ခုလုံးကဒီကောင်ကဟို solid like a instead of air filled sac it became a solid tissue ဖြစ်သွားပြီးတော့သူကအဲ့ဒါကိုဟိုအများကြီးပေါင်းလိုက်တဲ့ခါကျတော့ either ground glass ဒါမှမဟုတ်ရှင် consolidation ကိုတွေ့ရတာပေါ့ part of the process here is a cytokine release ဖြစ်ပြီးတော့ဒီ patient ရဲ့ဟို vital signs တွေဟလာ fever CRP တက်တာတို့ဟို tachycardia ဒါတွေက cytokine storm ပေါ့နော်ဒီ process တကယ်တော့ it happen with any ဟိုပါပေါ့ဒီ any viral pneumonia condition တွေမှာရှိတယ်ဟိုဆိုးတာနဲ့ဟိုနဲတာနဲ့များတာပဲကွာတာပေါ့နော် so အဲ့ဒီလိုဖြစ်လာလို့ရှင် patient ကဒီဟို respiratory failure ရတယ် oxygen level များတယ်တကယ်တော့ဒီချိန်မှာသူက mechanical ventilator ပေါ်ရောက်သွားတယ်ပေါ့နော်အဲ့တော့ဘာဖြစ်မလဲဆိုတော့နောက်ထပ် topic တွေကတော့ ARDS ရလို့ရှိရင်အရန်ဆိုးတယ် respiratory failure ရရင်သူကဟို mechanical ventilator ပေါ်ရောက်သွားတာဟုတ်လားအဲ့တော့မှမြင်တဲ့အတိုင်းပဲ there is a breathing tube in endotracheal ပြုဝင်နေတယ်ဟာဟိုဘေးမှာလည်း ventilator ရှိတယ်ဟို all the lines and drips and so many medication going at the same time but I'm going to skip that topic right ဘာကြောင့်ဆိုတော့ဒီဟာကit's applying to only in the ICU so I don't think it will be that useful but if there is a need to know about this topic I'm happy to share in what now my message for you yeah so the get ICU ကြောင်းပြောမယ်ဆိုလို့ရှိရင်တော့ ARDS ICU ဆိုရင်ဘာတွေပါလဲဆိုတော့ဟလာ patient က hypoxia ဖြစ်နေတဲ့ patient တွေကဒီ non invasive ventilation ဟလာ BiPAP တို့ CPAP ဟလာအဲ့ဒါတွေကြောင်းပြောရတယ်ပြီးတော့ mechanical ventilator care နဲ့ management ကြောင်းက topic တစ်ခုပြီးတော့ ABG တွေခဏခဏလောက်တော့ how you going to interpret the ABG how do we monitor the hemodynamic vital signs or PA pressure and so on and so forth now how do we manage the fluid what kind of fluid you're going to give now procedure ICU ထဲမှာလုပ်တဲ့ procedure တွေကတော့ intubation ရှိတယ် lines တွေ tubes တွေ lines ဆိုတာ chest tube တို့ဟလားဟို procedure တွေရှိတယ်ပေါ့နော်ဆိုတော့ဟိုခုန ARDS ပြောပြီးတော့ here's the example ပေါ့နော် so there are two patients ကတယောက်က require 2 liter to maintain saturation 90 another person require 10 liter to maintain O2 saturation 90% so saturation ကတော့တူတူပဲဒါပေမဲ့ require oxygen ကတော့မတူဘူးအဲ့တော့အဲ့နှစ်ခုကိုကြည့်မယ်ဆိုလို့ရှိရင်သူတို့နှစ်ခု question က are they in ARDS ပေါ့နော်မေးခွန်းကအဲ့တော့ဆိုတော့what is the level of care patient need so level of care တော့လေဆိုးလာလို့ရှိရင်တော့ inpatient care ဖြစ်သွားတာပေါ့နော် hospitalized လုပ်အောင်ပါပေါ့ဆိုတော့ well ARDS ဟုတ်မဟုတ်ကိုဘယ်လိုကြည့်မလဲခုနပြောတဲ့ chest x-ray လုပ်ရမယ် x-ray မှာ infiltrate bilateral infiltrate ဖြစ်ရမယ်တွေ့ရမယ်ပြီးတော့ဒီ reason for respiratory failure က not due to congestive heart failure ပေါ့နော်now criteria က arterial blood gas criteria တွေ့ရမှာပေါ့နော် definition က PaO2 divided by FiO2 has to be less than 200 second patient ကိုကြည့်မယ်ဆိုလို့ရှိရင်second patient ပဲဖြစ်ဖြစ် first patient ပဲဖြစ်ဖြစ်တကယ်တော့ saturation 90% ဆိုတာဒီ pressure နဲ့တွက်မယ်ဆိုရင်သူကဟိုလောက်ရှိ60 mm လောက်ရှိတယ်ဒီနံပါတ်ဘယ်ရရတာလဲဆိုတော့ oxygen hemoglobin dissociation curveကနေရတာ so saturation 90% is approximately 60 millimeter လောက်ရှိတယ်အဲ့တော့အဲ့ဒီဟာရဖို့အတွက်ကိုပေးတဲ့ oxygen ပမာဏက second patient က10 liter ဆိုတဲ့ခါကျတော့10 liter က FiO2 နဲ့တွက်ရင် 0.6 ရှိတယ်အဲ့ဒါဟိုရှိမှပြောတဲ့ဟိုဒီ oxygen flow rate နဲ့ percentage ကိုဟို estimated conversion ဟို chart လေးရှိတယ်အဲ့ chart တွေကနေပြန်ကြည့်လို့ရှိရင်10 liter လောက်ရပြီဆိုရင်အဲ့ဒါ equal to 60% FiO2 လောက်နဲ့ညီတယ်ပေါ့နော်ဆိုတော့ 60% ဆိုတာ 0.6 အဲ့တော့ခုနအပေါ်က formula တွေကိုထည့်ကြည့်လို့ရှိရင် the ratio is about 100 ပေါ့နော်ဆိုတော့တကယ်တော့ဒီ patient who require 10 liter of oxygen and saturation is only 90%, that is clinically in ARDS without doing blood gasပေါ့နော်အဲ့တော့ question does it really make difference to know or to define ARDS? Well, the answer is not necessarily. ARDS tell you that the patient is in severe respiratory failure. So, COVID လည်းဖြစ်လိုက်တော့တော်တော်များများကဟလာ2 liter 3 liter လိုပဲလို့ရှိတယ်ဒီထက်ဆိုးလာလို့ high flow လိုတဲ့လူတွေလည်းရှိတယ်10 liter ဟလာ concentrator နှစ်ခုပေါင်းပြီးတော့ပေးရတဲ့လူတွေလည်းရှိတယ်ဆိုတော့we all know that when they require more and more oxygen they look sicker and they are sick right doesn't so they သူတို့တော်တော်များများအကုန်လုံးကတော့ဒီလောက်ဆိုရင် ARDS level လောက်ဖြစ်နေပြီshould be taken care of in the hospital ဒါပေမဲ့အချိန်ကြီးကြောင့်မလို့most of them are they're at home ပေါ့နော်အဲ့ဒါလည်းနားလည်ပါတယ်အဲ့တော့it just tell you that how bad how sick the patients are treatment ကတော့လေARDS မို့လို့ဒီဖြင့်တကယ်တော့လေ ARDS level နဲ့ severe respiratory distress နဲ့ဟလာ ventilator လို့လဲကိုမလုံနိုင်တော့လေသူ့ရဲ့ resource ပေါ်မူတည်ပြီးတော့ oxygen ပဲပေးရမှာပေါ့နော် okay နောက်ထပ်တစ်ခုက ICU ထဲမှာတွေ့တာကနောက်ထပ် topic လေးတစ်ခုက pneumothorax and pneumomediastinum ဒါလေးကိုခဏလေးပြီးအောင်လို့ပြောလိုက်မယ်เนาะပြီးတော့မှ question လေးကိုwe take the question so pneumothorax နဲ့ pneumomediastinum က it's very common in sick patient from the COVID so the sicker the patient becomes the more likely patient will have it associated with pneumonia infiltrate could be spontaneous or could be barotrauma associated with positive pressure ventilation, either non-invasive or invasive. Pneumomediastinum is a condition where the air accumulates in the mediastinum. It does not need any treatment. Right? Pneumothorax, so it could be bilateral or unilateral, combined or maybe isolated with pneumomediastinum. See in the patient on the ventilator. Small so patient are spontaneously breathing, not on the positive pressure ventilator. Small pneumothorax, you don't need to do anything. But again, those patients can go into tension pneumothorax, so it's high risk today. Now, most of the time we have to put a chest tube in. Definitely, if they're on the ventilator, so yes, chest tube need to be placed because of the risk of tension pneumothorax, and it compromised the gas exchange. So it needs an immediate intervention. All right, when do you suspect those conditions? So the key is the clinical assessment, right? So if there is sudden change in clinical status, new onset chest pain, worsening, sudden worsening or hypoxemia, new onset hypotension. Hypotension is because of the tension, right? So when you have a pneumothorax and hypotension, most likely because that pneumothorax, what happened is we decrease the venous return to the heart, and that caused the hypertension. Crepitus under the skin. So the patient looked like a balloon. There's a fullness in the neck. That's where the air accumulates. Around the neck, chest wall, that's coming from the pneumomediastinum. Okay, I'll show you some picture of those here, okay? So this is the X-ray of a patient that we have. Patient, look at here. X-ray is not too bad. I will read it. Maybe it's a very soft ball, maybe a little bit of ground glass, but for most part it's normal looking. But you see that there's a little shadow here around the heart border. And then when you look at the neck, you see that that's a collection of the air. So it looked like this patient has pneumomediastinum. Patient is not on any positive pressure ventilation. It appears that this is a spontaneous pneumomediastinum, and the air travel in the center of the chest all the way to the neck. And you can feel it in the neck area, okay? All right, here's the next picture. You see how different? This is the same patient. This is a 60 years old patient. A few days later, patient condition worse. Patient was intubated. And the subcutaneous air got worse. It, spread to both sides, chest wall, neck. You see the end of the armpits here. And you also see that here's a chest tube place. Oh, let me show you the first one. This first one is, no. Here is a patient already have a chest tube placed on the right side. Okay, so this is a tension pneumothorax on the left side. You see that trachea is deviated to the right. The whole heart is pushed to the right side, and this lucency, that's a pneumothorax. Okay, so let's look at this one. So this patient is one of my patients who was intubated in the morning, about 9 in the morning. You see the endotracheal tube here in the center. And what you notice, is anyone notice anything on this? Well, we're talking about pneumomediastinum and pneumothorax. So you can tell there's a lot of subcutaneous air on the, on the neck and on the chest wall. Can anyone comment what do you notice, the new finding on this patient? X-ray, that patient was intubated about 9:30 in the morning, and we had an X-ray post-intubation. And I don't know, you see the, there's a pneumothorax on both sides, left and right. And on the left side, you see the pleural line. I don't know, you see my, I'm sorry. You see that pleural line? So that's a pleural line. And on the left side, on the right side, there is still pleural separation on the right side, but it's only at the apex. So patient has pneumothorax, bilateral pneumothorax, and I think there's still the pneumomediastinum right here. The cardiac border on the left side, you see that little air there. So the next step is, well, we put a chest tube on the left side, so now the lung re-expanded. And on the right side, I barely see the pneumothorax. Somehow it's still minimal. And now the topic are post-COVID shortness of breath and dyspnea. The post-COVID suragaro, the symptom maybe a month, maybe a few months later, or patients are very sick, get better, slowly recovering. That low persistent shortness of breath ရှိနေတာပေါ့အဲ့တော့စဉ်းစားမှာတော့ဒီ patient first question COVID မဖြစ်ခင်တုန်းကသူ့ရဲ့ဟာလား is it totally healthy လာဒါမှမဟုတ်လို့ရှိရင်ဟိုငကိုတွေက shortness of breath ရှိနေတဲ့လူနာလားပေါ့နော်ဟိုဒီနှစ်ခုခွဲဖို့လိုတာပေါ့ဒီငကိုတွေကဒီ shortness of breath နည်းနည်းရှိတဲ့လူနာတွေကကြတော့သူ့မှာ pre-existing lung condition ရှိနေလားဒါအောင်မေးတာပါအဲ့တော့ဟိုနောက်တစ်ခုက how bad is it ပေါ့နော် covid ကပိုအရင်ဖြစ်တော့ကဆိုရင်လေဟို recover ဖြစ်ဖို့ကကြာမယ် damage ပိုများတာပေါ့နော်နောက်အချိန်ကလည်းပဲဟလာဟို1လလား2လလားဟို6လကြာပြီလားပေါ့နော်ဟို6လကြာမှ shortness ရှိတဲ့ symptom ကနဲ့1လကြာမှဖြစ်တဲ့ symptom နှစ်ခုကဟို6လလောက်ကြာတဲ့အထိရှိနေလို့ရှိရင်တော့ပျောက်ဖို့တော့တိတ်တော့မလွယ်တော့ဘူးပေါ့နော်သူက chronic တော်ဖြစ်သွားပြီစောသေးရင်တော့လေသူကစောင့်မှုဟိုအချိန်နည်းနည်းရှိသေးတယ်ပေါ့နောက်တစ်ခုက shortness of breath ရတာတခုလည်းမဟုတ်ဘဲနဲ့ patient က အောက်ဆီဂျင်ကိုလိုလား saturation အောင်ကျနေတော့မယ်လားပေါ့နော်ဒါတွေမေးရမှာပေါ့differential diagnosis ကတော့ဟာလားဟို covid ဖြစ်တဲ့လူဆိုတော့လေ main အဓိကက it's because of the covid pneumonia ဆိုတော့ဒီသူက scarring ရှိတဲ့ lens တွေပြီးတော့တဖြည်းဖြည်းနဲ့ခုန fibroblast တွေဝင်လာပြီးတော့ initially ဝင်လာတော့နောက်ပိုင်းမှာ we call it fibrotic lung disease ပေါ့ scar တွေအများများပါတယ်ဒါမှမဟုတ်ဘဲနဲ့ရိုးရိုးလေးဒီ still improving stage မှာပေါ့နော် maybe 3-4 weeks after the covid မှာဆိုတော့ဟိုthere is a room to heal ပေါ့ဒါမှမဟုတ်ဘဲနဲ့ဟာလားဟို secondary pneumonia များရတာလားဆိုတော့အဲ့ဒါတွေက history ပေါ်မှာမူတည်တယ် physical ပေါ်မှာမူတည်တယ် clinical suspicions ပေါ်မှာမူတည်တယ်ပေါ့တချို့ patient တွေက covid ဖြစ်တယ်ကောင်းသွားတယ်ဒါပေမဲ့လို့သူကဟို activity နဲ့ weather change နဲ့ cough နဲ့ wheezing နဲ့ရတယ်ဆိုလို့ရှိရင်သူကဟို they behave like an asthma အဲ့ဒါကိုဟိုဒီ new onset airway disease ပေါ့တချို့ကြတော့လေဒီ they think that they're short of breath ဒါပေမဲ့ number တွေ chest x-ray အကုန်လုံးကောင်းနေတော့ is it psychological ပေါ့နော်နောက်တစ်ခုက covid long haul syndrome which is တကယ်တော့ it is real patient ကကောင်းတယ်ဒါပေမဲ့လို့ they never get back to their normal ပေါ့ they always feel fatigue tired ပေါ့နော်အဲ့ဒါဟို test လုပ်ကြည့်လိုက်ရင်လည်းဘာမှမပေါ်ဘူးပေါ့ doesn't sound like a covid related from the history but covid make it worse ဆိုလိုတာကတော့ဟို covid ကြောင့်ရလို့မဟုတ်ငကိုတွေကသူ့မှာ underlying lung condition ရှိနေတာပေါ့နော်အဲ့ဒါကတော့ဒီ chronic dyspnea ရဲ့ approach ပေါ့တချို့ဟာတွေကလည်းပဲဟလာ congestive heart failure တို့ pneumonia အဲ့ဒါလည်းစဉ်းစားရမှာအဲ့တော့ baseline ကတော့ chest x-ray သုံးပုံရင် CT scan depending on clinical suspicion now basic labs ရေဟလာ oxygen ကြည့်မယ် sputum protected sputum ဆိုလဲဟလာဒီ sputum culture analysis အဲ့ဒါတွေလုပ်မှာပေါ့နော် treatment well treatment ကတော့ဟလာဟို depending on the differential ပေါ့အဲ့တော့ဒီအချိန်ပေါ်မူတည်ပြီးတော့ဟာလာ image ကလည်း scarring လို့တွေ့ရတယ်ဆိုလို့ရှိရင်တော့ဟို oxygen လိုရင် oxygen ပေးမယ်ပြီးတော့ you need to exercise တချို့တွေက pregnant steroid တွေဆက်ပေးရရှိရတဲ့မဲ့ there is no clear role of steroid ပါokay secondary infection တေးကြတဲ့ pneumonia new consolidation ဆိုရင်တော့ဟို treat လုပ်မှာပေါ့နော်အဲ့တော့ဟို culture လောက်တာတော့ပိုကောင်းတယ်ဒါမှကိုက targeted antibiotic therapy ကိုပေးလို့ရတယ် new onset airway disease well wheezing နဲ့ဟိုငိမ့်နေအကောင့်တိုင်းမဲ့ exercise လုပ်လို့ရှိရင်ဟလာရာသီ weather change မှာဘာညာ wheezing တွေပါရလဲ short of breath ဆိုရင်တော့လည်း asthma လို့ treat လုပ်တယ်ပေါ့နော်ဆိုတော့ဘယ်လောက်ထိ treat လုပ်ရမယ်ဆိုတာကတော့လေဒီ patient symptom က chronic ဖြစ်လာရင်လည်းဒါ chronically treat လုပ်ဖို့လိုမှာပေါ့နော်ဆိုတော့ inhaler ပေါ့ inhale steroid လုပ်မယ် beta agonist တွေလုပ်မယ် psychological reassurance COVID long haul syndrome. Well, there's not much we can do. You need to understand this is how it is, and you have to exercise, fight the disease. Another topic is cough in general. So that post-COVID cough environment. All right. So cough in general. So post-COVID cough why do we cough, right? Post-COVID cough approach so because it's the same thing. When someone cough, it's because of those cough reflex, right? So you need to understand the cough receptor cough pathway the basic science refresh so cough reflex so location of the cough receptor. So look at pay attention to the location. So cough receptor so starting from larynx, supralaryngeal area, trachea, bronchi. So all the way, all the airway, the cough receptor is here. Now the ear canal and eardrum. So ear wax she needed to show this on one, but now let them ear wax cough now the pleural, pericardium, and diaphragm. Okay, so any irritation to the pleura, right? Pericardium irritation, diaphragmatic irritation, either below the diaphragm, irritate low level, cough esophagus and stomach, right? Stomach distension, esophageal irritation, the cough receptor is here. So cough one of the receptor in this area they are stimulated, and those stimulus is carried by the vagus nerve, which is the afferent nerve. Bring the the stimulus to the cough center in the medulla, and it's controlled by the higher cortical cerebellum control of it. Cortical modulation here. The cough you can control the cough to some degree. And from the cough center, here's the efferent nerve. So some of that, motor nerve go back through the spinal motor nerve and cause contraction of the expiratory muscle through the phrenic nerve, stimulate the diaphragm, and through the vagus nerve, go back to the larynx, trachea, and bronchi. And this is how cough happens. So cough to so diaphragm contraction or expiratory muscle contraction or cough reflex Where is it? Okay. So late effect of the post-COVID on respiratory system. So COVID, the effect of the COVID virus it's similar to any other viral infection. So flu, or rhinovirus, or any other, or URI virus, they go longer, cough will piss in the low, at the body. They cause usually transient inflammatory change, and then they get better, they resolve. Or some patients, they behave like a chronic airway inflammation, and they become like an asthmatic. Effect on the lungs. The COVID airway involved in patient cough shortness of breath Some of the patient has pneumonia because COVID get to the lung parenchyma, cause pneumonia, pneumonitis, acute lung injury, either they get better or they have residual minimal inflammatory change that continue for quite some time or become persistent and chronic. But when patient recover, there's a minimal scarring and patient is minimally symptomatic. Or if you're not lucky, some patients have chronic scarring, behave like an interstitial lung disease, such as pulmonary fibrosis. So this is like a summary of effect of the COVID virus on the respiratory system. Post-COVID cough. Well, so mostly it's because of the involvement of the airway. That's why people are coughing, or parenchyma, meaning that because of scarring. Scarring means the scarring involved the pleura, or so when you have a lot of scarring, take a deep breath, it stretch the lung, it stretch the pleura, and that's where you cough happen. So whenever you have a post-COVID cough, you ask the question, is patient behaving like an asthma, or is it scarring, ILD scarring, right? Another question is, how likely there is another pathology to explain the cough, such as, something else, right? Bacterial infection or acid reflux or any other pericardial effusion. So depending on what you find and what you suspect, that's how you're going to treat. Well, cough suppressant, basically that's a symptomatic treatment to suppress the cough if the cough is really bothering patients, couldn't sleep. Specific treatments are, well, if patient behaving like an asthma, you treat the asthma with asthma medication, steroid inhalers, beta agonist, short-acting, long-acting, muscarinic inhibitor. So all these things you can treat it. If patient has scarring, that's not really anything to treat. Those cases of scarring, you can't do much about it because steroid not gonna help, inhaler doesn't help. They just have to embrace it and keep fighting, exercising, hoping that over time, symptoms subside. If patient has continued inflammatory changes, persistent ground glass changes, that's not good. So that means now patient is behaving like a chronic interstitial lung disease. In those cases, sometimes we use a steroid, depending on how symptomatic patient is and based on the inflammatory changes. And then reassurance. Reassurance is you have to explain patient that why the cough is happening and nothing else. No, it's not a life-threatening condition, and hopefully with time, cough will subside. So we need a reassurance.